All right, now on to my favorite part, the exercise part. Because, of course, exercise is our main intervention, or not necessarily, but exercise is the common thing that we do in physical therapy. And no matter what setting you work in, you're going to be doing this. A lot of the things that we'll talk about today have definitely considerations for pulmonary disease, but also think about it with regard to your other patients as well. So with exercise considerations, we really want to make, particularly people with pulmonary disorders, because they have reduced vital capacity, reduced capacity to do things. And I think of it as like it's an energy budget. If you overspend your energy budget, then you can't do anything else. And so we don't want to overspend their energy budget with exercise that's not relevant, specific, functional, etc. So we want to make sure that the exercises that we choose are relevant to the patient's goals. So they might have very modest goals, like they want to be able to climb stairs, they want to be able to drive their car, they want to be able to grocery shop. Grocery shopping is incredibly strenuous when you have pulmonary disease. So that's something to work towards. Specificity, we want to train in the mode that we want to improve. So if that person's goal is to be able to walk their dog, we want to train walking. And we want to train walking on different surfaces because you're not usually walking the dog indoors on the treadmill, you're walking the dog outdoors. So specificity is important for any exercise that you do. It has to be functional. So sure, like doing strengthening exercises is good, but remember we have that energy budget to think about. So we want that person to get the most functional strength training that they can get. So if they want to work towards being able to do all their own self-care, like fixing your hair involves arm work. And so you maybe want to strengthen your arms in this range of motion. So it has to be functional. It has to be relevant to the patient's lifestyle. So the patient, do they want to play with their grandchildren? Do they like to bowl? Do they like to golf? Do they like to fish? What does that person like to do? Do they like to garden? Do they like to walk their dog? So I've had like several people tell me, like, I just want to be able to go fishing. Like, I understand that. You just want to walk down to the creek and go fishing. I get it. So you want to make sure that your exercise is relevant to what that patient wants to do. So our exercise physiology principles, what mode of exercise are we going to be doing? And with pulmonary rehab, we're mostly going to be doing cardiovascular, even though we're going to do some strength as well. So level surface walking, stationary bicycle, treadmill walking, outdoor walking, if that's functional and appropriate for the patient and, weather permitting. Duration, we want at least 20 minutes continuous or 30-minute interval training for the aerobic component. And we will talk specifically about how we're going to do that interval training for someone who's severely deconditioned. Frequency, it should be at least 3 days per week, but preferably 5 to 7 days per week. So your lungs don't get a break, so neither do you. So every day is preferable, honestly. Intensity, it's going to be variable for the patient. So some people cannot tolerate a higher intensity, and we're going to monitor with rate of perceived exertion, oxygen saturation, heart rate, and blood pressure in that order. So first, we're going to go with rate of perceived exertion, and then the other measures. So the PT is going to evaluate the pulmonary person. They are going to obtain a baseline on functional capacity or work capacity, oxygen needs, muscle strength. They are going to assess flexibility. So rib cage mobility is part of that. Also hamstring and gastroc soleus. A lot of people have tight hamstrings and gastroc soleus, which affects their functional mobility. Their posture. Common posture for pulmonary disorders: forward head, rounded shoulders, kyphosis, elevated shoulders, like the person in the picture. The PT is going to assess their function, their activities of daily living, a 3 or 4 meter gait speed, timed up and go test. Those are the functional tests, and we might retest those later. Their breathing mechanics, so pursed lip breathing, diaphragmatic breathing, accessory muscle use, use, paced breathing, their exercise limitations, what comorbidities they have, what musculoskeletal issues they have, and if they have any peripheral neuropathies, because that's going to affect walking and balance if they have that, and other things. The PT is also going to assess their psychosocial issues or psychosocial aspects of their recovery. Depression, anxiety, level of motivation. Even though we want them to exercise ideally 5 to 7 days per week, if they have depression and anxiety, they're not going to be very motivated to do it. Or if they get out of breath every time they do anything. We also want to take into account the patient's goals. Do they want to travel? Do they want to do community activities? Do they want to improve family relationships? So patient goal orientation is very, very, very important for motivation. And if they're able to travel and do community activities and improve family relationships, that can address depression and anxiety as well. So very important component. It's not just the exercise. The other things that the PT is going to look at is their function in ADLs, their prior level of function. What were they doing before? And, do they want to get to that, or is it possible? Their social and family support, and what are their greatest difficulties? And a lot of times when you're assessing patient goals, it's very difficult for them to pin things down. You might need to get them started. You ask them, like, what are your goals? And you might need to get them started, like, say, well, what are your hobbies? What do you do for fun? Do you have grandchildren? Do you have horses? I don't know. Whatever is the thing. This can be an emotional topic for some people because some people feel like they are never going to get back to doing what they want to do. And so good listening skills and active listening skills and being very empathetic and supportive of the patient's goals. And we'll talk a little bit about realistic goals as well. So a lot of people, because of their decreased muscle mass and their decreased vital capacity, they might be considered to be frail. That's going to affect what kind of exercise they can do. There is a criteria for frailty. More than 3 of these have to be present in order for someone to be considered frail. Unintentional weight loss of at least 10 pounds in the past year. Weak hand grip strength as measured with dynamometry, self-reported exhaustion, slow gait speed, low self-reported physical activity. So a lot of people will come in and they'll just say, well, I don't really do anything all day. So that's the low self-reported physical activity. So if someone's frail, that's going to change how we guide their exercise program. So the best pulmonary impairment-based outcome measures for assessing work capacity, the 6-minute walk test, we're all familiar with that. And we're going to measure if they're a pulmonary patient, we're going to measure their heart rate and their oxygen saturation. We want to get what their lowest was during the 6 minutes, their rate of perceived exertion. We also might use the dyspnea and subjective fatigue scales, the distance and the number and time of stops. If you're working with someone who has pulmonary disorders and may or may not be on oxygen, use the oxygen during the test. Allow the SpO2 to go down to 80 before you stop and rest. That is a very uncomfortable place for most of us. We don't want it to go down that low, but we really want to kind of see what's going on with the person. So let it go down to 80 before you stop them. The mid-range in adults with chronic respiratory disorders is between 25 and 33 meters. Remember when we did it in lab, it was a lot more than that for people without respiratory disorders. The median score for people with respiratory disorders is 30 meters. So that's not very far in 6 minutes. That's the study that found those median scores. The 2-minute step test might be more appropriate for someone that can't do 6 minutes. The 2-minute walk test is also another thing you can do as long as you retest the same thing. 30-second or 1-minute sit to stand tests endurance, and it specifically tests muscle endurance. So the short physical performance battery, the SPPB, is a group of 3 tests: the 5-time sit to stand, gait speed, and static balance using the Romberg. And so that one, it's short, it's easy to do, it assesses a lot of things, and it just gets a baseline of their physical performance. And then it compares to whether they're improving. So I use these all the time. And the 6-minute walk test all the time. Balance outcome measures: Berg balance scale, single leg stance, forward reach, which is part of the Berg as well. Strength outcome testing using handheld dynamometry, which is a little more objective than manual muscle testing, or gross functional muscle testing. That's also, can they do things? That's the functional part. So when we're trying to improve their work capacity or their endurance, basically, we want them to be able to get up to doing 20 to 30 minutes continuously. Most people, when they start, can't do that. So I was working with someone who we were trying to get him up to that, and chronic obstructive pulmonary disease. And at first he could do 3 minutes, and we worked our way up, and he could eventually do 20 to 30 minutes on a stationary bike. So level surface walking, treadmill, stationary biking, or arm ergometry. We want to work them up to 20 to 30 minutes. So the way we're going to work them up to that is through interval training. So work rest intervals for a given duration. So short activity bouts over a longer period of time. For someone with chronic pulmonary disease, a 2-to-1 ratio of rest to exercise is a good place to start. And their rest might not be, for someone who's active and healthy doing interval training, your rest time might be just your steady state aerobic pace. For someone with chronic pulmonary disease, their rest time might be sitting and resting. So like 2 minutes to rest to 1 minute of work, or 4 minutes of rest to 2 minutes of work. So that 2-to-1 ratio. And we're going to progress from that. So eventually we want to get them up to continuous, but they might not be able to do continuous. And we're going to do rate of perceived exertion, oxygen saturation, heart rate, and blood pressure in that order. So for strength training, we are going to use you can use high intensity weights, but if you're using low intensity weights, low poundage, high repetitions, focus on breathing in correct form. You can do dumbbells, cuff weights, TheraBands, whatever you want to do. High intensity weights, if you are doing high intensity weights, it's for someone with chronic pulmonary disease, it's better to use weight machines because it keeps their form more strict. So usually I will start people out with low pound, high rep for improving muscle strength, and work them up. You're working them up. So improving flexibility for chronic lung disease, you should stretch the anterior chest, gastroc and soleus, hamstrings, cervical and thoracic spine, and the rib cage. And we will come up with ideas in lab for what stretches we're going to do for that. So for improving their functional things, ADLs like dressing and self-care, you're going to work for activities that are working towards that. Household chores, yard work, and hobbies. I worked with one lady, and her hobby was knitting, as is mine, and we used to knit at the end of the session. It was lovely. It was a great session. But that's not, much as you might be surprised to hear this, knitting is not a cardiovascular activity or a strength training activity. Prior level of function, what did they do for work? What are their hobbies? What is their home environment like? So some people live on in a house that's all on one level, no stairs, blah, blah, blah. Some people live on a 3-level house with lots of stairs. So that person, you might be training stairs every time because they want to be able to improve their function at home. So improving psychosocial function, explore their support system. Do they have a spouse? Do they live alone? Do they have children, friends? Do they go to church? Do they belong to clubs? Sometimes I've talked with patients who they have like a group of people that they just get together for coffee every Thursday morning or whatever, that is so important just for their psychosocial function. A lot of times people have the greatest, we want to see what they have the greatest difficulty with. Is it just plain old breathing? We'll work on that. Do they have trouble walking? Do they have trouble vacuuming, which is one of the most difficult household chores? Do they have trouble climbing stairs, carrying objects, or doing any of those things while they're carrying objects? So that's important to check into, because if people can't do the things that they consider to be normal daily activities or connect with their support system, that is going to lead to depression and anxiety and possibly lack of motivation as well. So improving breathing mechanics, we're going to do breathing retraining, diaphragmatic breathing, pursed lip breathing. We want to discourage use of accessory muscles. We want to instruct in paced breathing with exercise. So telling people when to inhale and when to exhale during exercise is important. We want to address other limitations to their therapy or their rehabilitation. Comorbidities that they might have, any physical limitations that they have, their home environment, financial limitations. So maybe they can't come in 3 times a week because their copay is too high with their insurance, but maybe they can come in once a week to start with and then cut down to once every other week, so they can check in with you and finish. So we can help address those. Treating psychosocial status is a huge, important thing because people are not going to improve if they're not motivated to do it. So I like to talk about the power of group exercise. When people exercise with other people, they have more fun and they're more motivated to go. So that is, if a lot of times I will recommend different group exercise programs and everything to people. Depending on what area you live in, there are going to be different things available. Get to know the group exercise opportunities in your area so you can refer your patients appropriately, because they're more likely to do it if they're doing it with other people. Support groups can be really helpful because you're talking to people who are going through the same thing you are. Stress management can be very helpful. Incorporating the patient's goals. So sometimes you have to help the patient make the connection between the exercise that you're asking them to do and their goals. And also dream versus reality. Like the person might say, well, I want to get off oxygen entirely. They might not be able to get off oxygen entirely, but they might be able to reduce their supplemental oxygen needs. They might be able to develop more activities that they can do with supplemental oxygen. Identifying community resources, like I was saying, kind of know what's going on in your community and know where you can refer people. Think creatively and work with that person to achieve their goals and help them make that connection between their goals and the exercise treatments. So many people say to me, if I say, well, here's the reason we're doing this, and they say, wow, that really helps me. I know why I'm doing it, and that makes me want to do it more. So very important. A lot of times I will, when I'm talking with patients, no matter what, if they're like rehabbing from surgery or whatever they're coming into therapy for, I'll say, well, what do you want to get back to doing when you're done with this? And a lot of people have a specific thing. Like they say, I want to get back to gardening. I want to play with my grandchildren. I want to get back to playing golf. People have different goals, and then work towards those goals, because when you work towards their goals, you're helping them be more engaged in their therapy, and they're going to get better results. So we're going to progress exercise using the rate of perceived exertion. So for people with chronic lung problems, we want to work between 4 and 6 on the 10 scale. On the 20 scale, 0 to 20, we want to work between 12 and 13. So that's like somewhat hard. If we're measuring oxygen saturation, we want to keep above 88 to 90. People with chronic pulmonary disease tend to come out lower, so don't freak if it's 88. They kind of live in those lower saturation numbers, but we want to keep it consistent throughout the exercise session. When we're increasing workloads, the first thing we want to increase is time that they're doing it, or duration. The next thing we want to increase is resistance. We want to decrease the number of rest stops they need. So maybe they do it for 20 minutes with 3 rests. Maybe we can cut down to 20 minutes with 2 rests, 20 minutes with 1 rest, and then 20 minutes with no rest. And then increasing the number of repetitions that they're doing to the point where then you need to increase their resistance again. So we're going to gradually increase the workloads, and we're going to educate our patients in how they're going to safely do that. So with rate of perceived exertion, if you're always working in that somewhat hard range, you're going to be increasing your workload because it's going to take more work to get to that somewhat hard range when you're in better condition. So the rate of perceived exertion is a great way to work on progressing your exercise. So this is the reminder, this is the 20, the Borg scale. So in that 12 to 13 range. So where you feel like you're developing your aerobic system, like maybe you're breathing a little bit harder, somewhat hard. You can hear your breathing, but you're not struggling in that, that yellow to orange transition is where they want to be. And on the 1 to 10 scale, that's between 4 and 6. On the 20 scale, it's between 12 and 13. That's where they want to work. So if they're continually working on that scale and they're doing it consistently, they're going to get better. They're going to improve their endurance because they'll be able to do less exertion with more work. So hopefully that makes sense. And that's for everybody, not just for people with chronic lung disease, but of course, with chronic lung disease, we have to approach it a little bit more slowly.